Hi everyone, I just wanted to pick up a little bit to finish as promised with a video of the rest of our material. Grace did a great job with our molar pregnancy, and I just alert you here to make sure you're well aware of the symptoms, right, and the risk factors, which are here and from Grace's case. I know that we are going to talk about this next week, so make sure you have a good sense of this going into it, because we will start class going over Previa, but it is good to look at those risk factors and to see. And we alluded about this today, about why we don't do vaginal exams on somebody who comes in with undiagnosed bleeding in that second and third trimester. And it's because if the placenta is the first thing over the cervix, we would cause a lot more bleeding. I know we talked about a speculum exam today. Even if we're expecting a previa, we wouldn't really put anything in the vagina. It's less traumatic than fingers, but we really would just avoid anything until we've ruled out where that previa is, or where that placenta is, I should say. I know we're going to talk about it, but I'm showing you here that you have the cervix right here, which is this line. So that's the internal os of the cervix. This whole area is the cervix, but this line is the os. And then you can see that here is the edge of the placenta. And then here's baby's head right here. And so the placenta is the first thing that's presenting. And I don't want to steal Kirsten's thunder, so I'm going to leave it at that. Abruption, I know that was the last thing we spoke about given Stephanie's case. You guys want to flush out all of these risk factors, but really remember that most of what's causing this is vasoconstriction. So a mom who's hypertensive, which Stephanie nicely put in her case, that woman has had PEC without severe features in Stephanie's case, so that is definitely somebody who's at risk, or somebody with chronic hypertension as well. Cocaine use, cigarette smoking, those things we spoke about. The other big thing we didn't say out loud is trauma. So any blunt trauma to the belly. This is also why pregnant women can't ride roller coasters or have severe, stops and starts to their belly, because that could cause it. Clinical symptoms to not forget is a rigid board-like abdomen, and they don't always present with bleeding if the bleeding is still concealed, meaning it hasn't come out yet. But rigid board-like abdomen is usually your high sign here. And this is a really big emergency. They need to be delivered, 2 minutes ago. So delivery. Interestingly, I wanted to go over the pathophysiology a little bit, because the hemorrhage is happening in the decidual basalis, which is part of where the placenta has adhered to mom's uterus. And then that separation gets bigger and bigger because of that blood that has formed there. And then it causes the placenta to separate. Interestingly, and why this is probably linked to preeclampsia, is that this abruption happens with a rupture inside of those spiral arteries. So if you go back and you think about the spiral arteries, we also saw that going on with preeclampsia, an issue with how the spiral arteries were formed. So it is very interesting to think about this connection. We talked about the management options for partial. I gave you that example of my friend's sister. They would be put on sort of a modified bed rest because they're actively bleeding if they're remote from term, or to try to get somebody from viability. And then usually our threshold for a heavy bleed once they've reached viability would be to deliver them, just because of all the risks that are going on. And the only other thing that I wanted to mention was, again, to really focus on sort of that connection, that this is happening because of vasoconstriction. If somebody has an increased alpha fetal protein, we know that they could be at risk for an abruption. A clinical case I shared with you guys, a patient that abrupted had no other risk factors other than an increased AFP. So I just throw that out to remember. There's a video here of this and abruption. And with all of these things that we talked about today, an abortion, spontaneous, an elective, an ectopic pregnancy, a molar, any of these things, previa with bleeding, the patient needs to get RhoGAM if she's Rh negative. It's incredibly important. So just think about that and remember that with all of these conditions. And the other thing I wanted to say, I don't want to fly back through the slides, but on my first or second, I think it was the third or fourth slide actually, I had said, oh, I misspoke and put, okay, when somebody's having bleeding for the TAB, I used as the abbreviation. What I meant there was the number one sign of a threatened AB. So I put TAB and told you to correct it to SAB. But the reason I had the T there was to say I was using the term threatened, and I'm sorry that I hadn't seen that this morning or thought of that when I told you. But you know, just because somebody has bleeding in pregnancy doesn't mean they're actually having a miscarriage. It's a threatened miscarriage until we get all the facts going and have the ultrasound. So teratogens is actually really something that that would be me just speaking at you. So I'm going to give you the resources to learn about teratogens in and of yourself. We've talked a lot about substance teratogens. We've talked a lot about infection teratogens, and we're going to continue that infection piece in depth next week with when we talk about common illnesses. But I link here, and I want you to follow these purple links, which are the CDC's list of medications in pregnancy and this mother-to-baby resource. The mother-to-baby one specifically to bookmark for yourself because they allow you as the healthcare professional to call them, to put your patient on a registry to say, hey, my patient's on this. I know it's not usually a safe med. Can they follow her? So there's national registries that try to follow patients who are pregnant that are on medications that are known to not be safe and potential teratogens so that they can follow what the outcome is on that. The CDC tries to maintain a list of medications that are safe versus unsafe in pregnancy. So again, I give you these resources. I want you to explore both those websites to really grasp this material. Over here on the other side, we have a list of medications that are toxins and are teratogens, so that you know. And also on the bottom, I put tamoxifen. So be familiar with those. The other thing that I have a link here to is the FDA's new classification on medication use in pregnancy. So down here is the former way we categorized medications. So we used to say A, B, C, D, and X. It wasn't very clear because basically C and D were very similar. Hardly anything fell in an A, and A was like Tylenol and Synthroid, because for your hypothyroidism patient, Synthroid is safe, but really not much fell in A. And then there were some in B, and almost everything was a C. And so that left people sort of saying, well, can I take it or can I not? Because, you know, you can't tell me there's not a risk. So things move slowly when it's a government mandate. So I leave this because you may still see it, is still in Varney's. Williams, however, references this new labeling system, which I'm circling up here. The new labeling system went into place 2 years ago, but you know, as I said, the government things move slow. But what they're supposed to be doing now is labeling all medications with what exactly the potential risk during pregnancy, lactation, or if you're of reproductive age thinking of getting pregnant, what specifically the risks are for taking this medication. So meaning the package insert on medication should come with a lengthy list. And if you read this over here, the FDA new pregnancy classification, and follow that link, you can educate yourself on this new way because this is how your patients will be getting their medications labeled. The other teratogen that I had written a case study on that we hadn't gotten to, I apologize, last week, is Zika. And it is arguably one of our biggest teratogens with severe effects that's happening right now. So I link you to both the CDC and that mother to baby resource page that have up-to-date information. I also put here a picture of a baby affected with Zika, and also the current recommendations for both testing and travel. I will tell you that these are changing every few months as they're finding out more about Zika, so they're not something to commit to memory, but what they are there to know that Zika is a teratogen, that it causes microcephaly, so small head, and to know that pregnant women should not be traveling to areas with Zika. The other thing with it is if your pregnant patient has recently traveled, she should avoid getting pregnant for when she comes back. But the bigger piece to this is that if her partner has traveled to a Zika infected location, they're not testing him prophylactically, but they need to wait at least 6 months as a couple if he's the one who traveled, because it can live in the male reproductive system for up to 6 months. So my husband and I went to Cuba this summer, and there is obviously Zika there, and so it was a real conversation that we had, and that, you know, is something we need to think about. So 6 months for a male. For women, it's about 6 weeks that they recommend, 6 to 8 weeks, but for men, 6 months, which is a really big time frame, and they need to be educated about it. So please, for teratogens, explore all those websites, and it was a great class today.